Hi, everybody. My name is James. I'm a physician assistant and host of PA Mentor. And today we're doing a virtual shadowing session with Kristen. And I'll just let Kristen go ahead and introduce herself and take over. Thank you.
Awesome. So my name is Kristen. I'm a PA and I'm also an IBCLC now, which kind of goes along with what I do at work, and I could explain that a little bit more. I started out, my background is biomedical engineering. Graduated, I had no idea what I wanted to do, if I wanted to go for a PhD, if I wanted to go to med school, I had no idea. So I worked a little bit as a clinical research coordinator for neurosurgery. And then I was writing these protocols and we had to hire a clinical nurse to train people. And I was like, this is the silliest thing ever because I'm writing these protocols. I know them better than anybody else. I'm going back to school and I'm getting a degree. Once I went back to school and I did my rotations, I did one day in a neuro ICU and that was enough for me. If I had to sternal rub another patient, I was good. So then right out of school, I went into emergency medicine and I loved it. And I think it was like a great career start. Gave you you got to see a little bit of everything, every age group, everything you could think of. People come from everything from med refills to lacerations to traumas. It was a level and trauma center. And then I had my little one and wanted to be home a little bit more because the hours in the ER, a little bit wacky. And when I had 4 different babysitters, I figured it was time to pull it back. So then I went into pediatrics. I worked at my first practice for about 2 years. And then I've been at this practice for, I guess, 4.5 years now and absolutely love it. It's nice to be able to enjoy your workday and look forward to going there. And it's not really a job. I know people say it's not a job when you really like it, but it's not. I guess this is the first job that I felt like really comfortable with too. And I know that over time you kind of get that more comfort, but especially in the ER right away, like I just kind of felt so on edge all the time, like always worrying. The worrying doesn't go away, but it does calm down a little bit when you get more comfortable and just having that confidence. And I feel like the more confidence you show the patients, kind of the more they trust you.
Okay, and I forgot to mention as well, Christina, we have one of our PA students we worked with a couple of years ago. Christine, go ahead and tell everybody where you're attending PA school.
I'm Christy. I go to PA school at FSU, and I worked with James a couple of years ago. He helped me get in. So that was the one and only time I had to apply, thankfully.
And you'll be starting clinicals in about 6 weeks, right? Yeah,
starting clinicals January 3rd. So yeah, just
awesome.
About 6 weeks.
Awesome. Okay. Well, I think, is this when you want to do the case presentations?
Sure. I guess the other thing that I wanted to throw in, just because people are kind of applying at this point, is the one other thing that I did that was a little bit different is I did a part-time program for PA school. So I worked for my first year and did some of the courses and then full-time courses and then full-time clinicals after that. It works for some people. Looking back, I wish that I would have done the full-time program from the start. All of the really difficult classes, you still have to take together because they all overlap. So what you're learning in pharm, what you're learning in clin skills, what you're learning in PE, all overlap. So you're kind of just getting those ethics and the courses where you're just writing papers out of the way during that first year. So it was very frustrating when I saw all of the people that I start with getting out there and getting jobs, and I still had a whole nother year ahead of me. So in a way it was nice because I was able to work and save some money, but PA school is very mentally draining as well. So if you have the ability to do it full time, I would definitely say that's the way to go.
Wow. I didn't even know they offer that, or are they still doing that?
I think so. Drexel's had it for a while. So I went to Drexel. Not very many programs had it. So it was one of the reasons why I applied because I loved my job in clinical research, which is why I was going back. I wanted to stay there as long as I could. So, okay.
All right.
So we go next. So kind of general things. Everybody in the news right now, everybody's hearing RSV, TikTok, Facebook, no matter where you're at, this is all you're hearing. People come in, what is that RVS? What is that VSR? They think it's like the plague. And then you have to explain RSV, respiratory syncytial virus. It's been around for a very long time. So what is the presentation? Pretty much, I work in a local community practice. You get one kid, you know that everybody else from that daycare is coming in within the next 2 weeks with RSV. So the kid's gonna present like your common cold to begin with. They're gonna present runny, stuffy nose, cough. Sometimes they're making weird sounds when they're breathing. They can't breathe out of their nose. When they lay down at night, they're coughing worse because of all the post-nasal drip. And then, so what do? You do your exam. Most of these kids are on their third or fourth cold for the season. So now ears are totally inflamed, infected, because we've never had time to clear these tubes because we've had these back-to-back viruses. So usually you look in the ears, first thing you find is an ear infection. It's still on the other slide. You go back to the previous one. It's okay. Then you'll listen to their lungs, and a lot of times you just hear these coarse breath sounds in all fields because RSV is a bronchiolitis. So it's those really small areas in the lung that it's affecting, and you'll hear this like just diffuse coarse sound in these kids' lungs, and you can pretty much call it after you've seen it a bunch of times. Some parents want to see a test. A lot of parents want names for things. They want to know, my kid has adenovirus, my kid has parainfluenza. So totally, I will test them. I send one swab, a test for flu, COVID, RSV, all in one, so the parent could have the name. And so many parents will come back for the follow-up, be like, yeah, you were right, it was RSV. I know, we just charged our insurance a lot of money, but sure, we got our diagnosis. But what do? The treatment really is saline and suction. And parents all the time, oh, I can't hold my kid down for the saline and suction. You can, you have to. And I always tell them, you're going to end up in the ER. And what are they going to do? They're going to do saline and hook your kid up to deep suction on the wall. And you're going to get really upset when you pay $500. And then you're going to come back to me and be like, I paid $500 in the ER and they suctioned my kid. I said, so I sound like a broken record, but saline and suction, saline and suction, saline and suction. And then kind of just like the regular over-the-counter stuff. But what is the most important part of those RSV visits is telling parents when things get scary. So people are always afraid they're going to miss it. And a lot of times, we did have one case yesterday where the kid came in with stridor and croup and came into our office, and we had to call an ambulance. But most of the time, the parents will catch, will be like, this isn't my kid isn't acting right. So we tell them, watch for wet diapers, because normally this is really little kids. We want to make sure they're having 4 to 5 wet diapers a day. When they're breathing really quick, they're febrile, they're going to get dehydrated pretty quickly. A lot of them don't want to eat when they're not feeling good. So keeping them well hydrated. We teach them how to count breaths in the office. A lot of them want these pulse ox things. I don't know your experience with the kid pulse ox. We've had so many false alarms, parents come in freaking out. The kid's pulse ox is 70%, and the kid's up happy playing. I'm like, if your kid's pulse ox was 70%, your kid wouldn't be acting like that. You would know. So instead of talking about getting owlets or whatever they're called for the pulse ox, we teach them how to do breath counts and teach them when they're belly breathing, if they're breathing 60 breaths a minute, if the skin's retracting between their ribs, if their little nose is flaring. And then the other caveat I always give is, because a lot of these are new parents, first-time parents, and they get really nervous. And every once in a while, they'll just have like a normal, healthy kid go, and the little nose is flaring, and they'll go, and then they're fine again. I'm like, that's not what we're looking for. We're looking for persistence. This isn't going to stop after a couple of seconds. You give these caveats so you don't get these calls at 3 o'clock in the morning. Mm-hmm. But I think the most important education on RSV, which is what everybody's asking about right now, is when does it get scary and when do you know what the next step is. If you go to the hospital, what are they going to do? They're going to do oxygen. They're going to do saline, suction, oxygen. So that's why there's no treatment at home, because you don't have an oxygen machine at home for them. Mm-hmm. But I figured that was the big one to talk about today because it's just everywhere in the news.
Right.
Another thing that we're seeing a lot in our area is hand, foot, mouth. This starts off as your regular cold, fever, runny, stuffy nose. Kids get better like the next day. So usually a Friday night, Saturday, kid's not feeling good. Sunday, they're fine. Monday, we send them to school. By lunchtime Monday, we're getting a call. Kid's got a rash. Nah, it's not hand, foot, mouth. It's not on their hands and feet. It's everywhere. There's 2 strains of hand, foot, mouth. Sometimes it is just hand, foot, mouth. A lot of times the first place we see it is on the butt. It's fecal oral spread. So when these kids are in diapers, I've checked and they're like, oh, they've had a diaper rash for 2 days. That's not a diaper rash. That's the start of hand, foot, mouth. And again, it's really comfort measures, but it's one of those things that parents usually think they're out of the woodwork because they have this fever, runny, stuffy nose, fever goes away. They're like, they're getting better. And then the rash comes out. This is before COVID. I feel like there was a hand, foot, mouth season. Once COVID happened and masking, there is like no season for anything in our outpatient practice. We are seeing this year round. Ironically, there was like an outbreak in a 1st and 2nd grade classroom this week in our area. So we had like we have like a hand, foot, mouth handout for daycare. Like you can return on such and such a day. And we actually had to redo the handout because it's like good hand washing after diapers. We're like, these kids are in 1st and 2nd grade, but usually we don't see it that old. So everything's kind of been a little bit messed up since masking and COVID, and now kids going back into the daycare environment after being home and kind of in a little bubble for the past few years. The next thing that we always talk about at all visits, well visits, sick visits, are childhood immunizations. This is not stressed enough. The more we immunize, the less we're going to have a lot of these outbreaks that we're having. I mean, we've been seeing all different stuff. There was polio in New York this summer. There's been all kinds of crazy stuff that we haven't seen in years because people aren't getting vaccinated and they're kind of crossing their fingers and say, everybody else is vaccinated, I don't need to do it. No, everybody needs to be vaccinated. Some parents who are supposedly like non-vaxxers are kind of just scared and really just need education. So we'll actually set up a visit for these patients. We're like, you're going to have a 30-minute visit. It could be a televisit. It could be an in-person visit. It doesn't matter. But we want to talk about what your concerns are with the vaccines. And usually through that conversation, we can at least educate them enough to be like, okay, you know what? I'm comfortable with A, B, and C vaccines. So maybe I'm not going to get every childhood vaccine, or I'm not going to get them all at once, but I'm at least willing to consider them and start vaccinating my child. So that's always a good way to kind of reestablish getting people protected. And some people get frustrated because we ask at every visit, but you never know what that changing factor is going to be. Somebody in their family got an illness that, oh, they could have been vaccinated for. Somebody ended up with pertussis. Oh, what if my kid gave it to grandma? You never know what it's going to be. So always ask. And that's what they say, the Make Every Visit Count campaign. You'll have some kids that are non-vaxxers, don't come to the routine visits, only show up in your office when they're sick. You can have a busy clinic day and you're not really looking that they missed their well visit for the past 3 years. But we always say, just look at those immunization records, because even if they haven't been here for 3 years, if they don't have a high fever and they just had this runny nose for 3 weeks, you could give them shots. So make every visit count. And that's something to just never forget as you go through your practice. Another big topic in pediatrics recently has been the developmental milestones, when to check every single visit, just because they're not due for a well visit. If you notice a kid at a visit who's flapping, not making eye contact, toe walking, bring it up. Sometimes at the visits, we'll have kids that are so scared, they sit on the parent's lap like this the whole time. We don't get to see them talk. We don't get to see them do anything. The parents are answering yes, yes, yes. They're doing all of this. They're checking all these boxes. Come in for a sick visit. Now the kid's running around because they just have, I don't know what, a rash for hand, foot, mouth, but they're feeling fine. And you see that this kid is toe walking and flapping, and nobody's brought it up to the parent, because every time we've seen them in the office, the parent prefaces, you're going in for shots today. And now the kid's like this, and you don't actually get to see them interact. So bring it up at every visit. Don't just assume that somebody else has brought it up before. The sooner we get these kids help, the better. Especially with our kids who are diagnosed on the spectrum. If we get those kids help and assistance and the therapies they need starting at 18 months, these kids have great outcomes. And they just have such a good support system instead of kind of running through life and just trying to make it day by day. And some controversy that's come up in the pediatric world is that for the first time in a long time, the CDC has changed the age range for some of the developmental milestones. So crawling is no longer a milestone. Crawling used to be a 6-month milestone. You have to crawl at 6 months or you're getting sent to physical therapy. You don't need to crawl anymore. Waving used to be a 9-month milestone, like wave bye-bye. Now it's a 12-month milestone. The speech world hates this because all of the speech things. So it was like 2 words together by 2 years. Now it's like 2.5 or 3 years. So everything's gotten delayed. It was a very quiet thing that happened. And the reasoning for it was that the previous milestones were what 50% of the kids were doing. And now they changed it to be what 75% of the kids are doing, AKA early intervention was getting like really overwhelmed. And so they decided to make some changes. So there is some research behind it, but it's very controversial in the pediatric world right now. And a lot of people are still referring, like, listen, we've been doing this my boss has been doing this for like 30 years. She's like, I'm not all of a sudden going to change my practice because you changed the checklist. Like if the kid's not doing this, I'm going to get them the help and the assistance they need.
Okay.
And that's it.
Well, that's interesting. I didn't even know about I haven't done really actually peds for a while, but I didn't know about that change with the development.
It wasn't very well publicized.
Yeah, I bet it's under the radar, but
yeah,
I just, I don't know. I don't understand why you'd want to, because if you're delaying that treatment that they could benefit from, then how much worse is it going to be I don't know if there's something actually going on. But. All right. So how about if you just tell us a little bit about like day in a life in pediatrics?
Yeah, so a typical day, we do a combination of things. We do well visits, sick visits. Some people that I know, like they only do sick visits and their attendings do the well visits, or vice versa, or the attending comes in on all the well visits. So each day is going to be different depending on your attending. My attending is absolutely amazing, and I absolutely love her. I really lucked out getting the job that I have. She's very trustworthy, and she knows that I'm going to come to her when I have questions. And I'm always honest with parents too, and I tell them, you know what? I haven't seen that before, but my attending's been doing this a lot longer than me. I'm going to go grab her, you know? And sometimes she's like, you know what, we're going to grab the other attending and we're going to see. Sometimes medicine is a big puzzle. So everybody's day is going to be a little bit different. So my typical day is I go in, the first thing we do is check labs. Why? Because we have 800 COVID flu RSV tests outstanding from the day before, and 800 emails from parents being like, can my kid go back to school today? Is their COVID test negative? So the first thing that I do when I come in the morning is respond to all those COVID flu RSV exams, tests, so we can get these kids back in school. Because that's parents, not that it's their number one concern, but it's a big concern. Parents have to work when kids have these back-to-back holds. They can't come in without a negative COVID PCR. The parents need to know. So that's usually how I start my day. And if we back up before that, before I even get into the office, we have a portal where our patients can email us messages. So the first thing that I do is I actually wake up in the morning, and instead of going on Facebook or Instagram, I pull up our patient portal and I kind of see, do any of these people need to be brought in this morning, or any of these urgent? Is there anything that I need to respond to, or any parents I need to call on the way in, just to kind of get things out of the day, because you just never know how hectic it's going to be once you get there. So start with the patient messages. By the time we get there, we're up to the labs, and then either running into a well visit or a sick visit. In our practice, we see everyone from newborns up to the age of 21. We try to kick them out starting at 18, but we have a lot of lingerers that they're like, well, our insurance says we can still come here, and they won't kick out, which is fine, because they've usually been coming to us for a long time and we love them. But eventually I'm like, I don't practice adult medicine. I don't know what to do with your cholesterol as an adult. So all different age ranges. We were talking before this started. The area that I'm in is pretty much Center City, Philadelphia. So a lot of times what we'll see is we have these kids up until school age, around 6, 7, 8 years old, sometimes up to middle school. Then the kids move to the suburbs because they want different education systems. So we have a pretty, what I like to call, young practice. Not that we haven't been there long, but just that the kids are really young in the practice. So nowadays, this is usually our slow time right before the holidays, where we're doing some well visits. Everybody got their back to school well visits in. We're doing a few well visits. We usually have a little bit of downtime to catch up on faxes and things like that, so we don't have to do it during lunch. But we have been so slammed with these sick visits because flu season has hit so early this year. I did 12 swabs yesterday, and 8 of them were flu and 4 were RSV. And by the patient's age, you could have figured it out before you even ran the test. So all of my 7 and up are flu positive. All of my 5 and under are RSV positive. And if they're in that in between, or they have older or younger siblings, that's really when we need to test to find out. But yeah, my day totally varies based on how many well visits, how many sick visits. In addition, totally not PA related, but in pediatrics, since we have a young practice, I went back to school and became a I got a certification, so International Board Certified Lactation Consultant. So it was like an 8-hour international exam, and it has been a great addition to the practice. So in addition to like my PA visits, I also do lactation visits, which the parents love because they come and it's a lactation visit, but it's also a medical visit. So like, is the circumcision healing well? Is the cord dried up? Can my baby take a bath? All of these just general medical questions that you wouldn't be able to ask at a lactation visit. So it's kind of an all-in-one stop for them. So I feel like it actually has brought us a lot more business too, because parents are like, oh, wait, we don't have to like find one person for this and one person for that. You guys kind of cover all the bases there. So
do you also, like your age, is it all like under 10 or is it really across the board?
It's really across the board. I see a lot of the babies, like most of my kids are like under 5. And I really think it's because my attending's been there for so long. So the kids that have been seeing her for 13 years, they're coming back once a year for well visits. So I'll see them more for sick visits. But if they're coming once a year for a well visit, they're going to go back to my attending because they've been seeing her for so long. So I feel like the group that I've established is mostly like that under 5, under 6, because I've been there for about 4 years age group. So I'll see all ages, especially for sick visits. But I feel like especially those older teens that have been seeing my boss for 13 years tend to go back to her for their once a year visits.
I mean, I did a peds rotation. I knew this was not my field. I I'll never forget the girl that made up my mind. It was a little girl, I don't remember her age, but she like junk all over her face. And she leaned in, I leaned in, I take my stethoscope, I lean in a little closer. She grabbed my tie and she wipes her face with it. Like, wow, I did not know you should buy like dollar ties from Target or something. I'm a nice tie on, like little scissors, like clip this thing off. Like, okay, well, that's gone. If anybody has any questions, feel free to ask. Christina, if there are any questions, feel free to.
Yeah, so Kayla has a question. She wants to know, what are some key details I should look for when applying to PA school?
So I don't know which end of applying for PA school. So key details and like what to look for in a school or a program, or I'm not quite sure.
Good question.
How I like to describe, I don't know if this is going to answer, but how I like to describe applying for PA school is like it's a relationship. So you're going to interview for some schools and you'll be like, you know what, maybe I'll get in there, but that is not the fit for me. You're not going to go with that school. I don't know if you have different advice, but I know people like PA school is really mentally difficult. It's psychologically difficult. When they say you're drinking from a fire hose, they're not lying. So if you go into a program and you don't feel supported by that program going in, it's not going to be a great experience for you. So I really say use it as much as they're interviewing you, you're interviewing them as well to make sure you're a good fit there. I had an interview that I went on, and just by the questions they were asking and their tone, I was like, this isn't going to be for me. And I kind of just knew it getting out of that interview, just the questions that they asked and how they asked it. And then when I ended up going to Drexel, when I went for the interview there, for lack of a better term, it felt like home. Like I felt comfortable when I was answering questions there. It just felt like a good fit. So the key details are going to be different for everybody, I think, and it's going to be depending on your lifestyle, your personality, and what works for you.
Thank you. And for the record, I totally agree. You know, you just kind of rank what's most important to you. So. Yeah. Kendall has a question, and she would like to know, how was your transition from the emergency department to pediatrics? And was it hard to switch fields when you were applying for your different jobs?
So it wasn't difficult to switch fields. I actually overlapped my two jobs because you have to give so much notice in the emergency department. So I had about a few weeks, almost like a 1 month period where I was doing ER nights and weekends and the PA job during the day and not sleeping and just surviving to get through that transition. But the supervising physician that I got a job with was awesome. What I was most nervous about, I knew what to do with a sick kid. You hand me a sick kid, we would see sick kids in the ER all the time. I got that. I got it covered. They sent me into a well visit. I was like, I don't know what to do. My kid was like 6 months at the time. I didn't know what the 3-year-old was supposed to be doing, you know? So it all depends on your attending. I didn't go for any of like the residencies or anything like that afterwards. I shadowed my attending, read a bunch of books. Then it was kind of do one, teach one, do one, see one, that whole thing. And he would see a patient, I would see a patient, he would come in and watch, and then I do one on my own. And once we had done a couple of each age group, he's like, okay, you're on your own. If you need anything, let me know. And then I think it's been good too, because even at my practice now, I'll still go to my attending. I'm like, what is your spiel for this? So again, like I said, she sees most of the teenagers, and I had a teenage boy come in yesterday. And he's like really having a problem, like a hard time making friends, like lots of bullying at school. And I kind of gave him like a roundabout spiel, but I'll still go to my attending and be like, okay, what is your spiel for this? And still get information like and like every once in a while we'll sit down like all three of the docs that I work with together. And we're like, okay, what are you doing when kids are coming in with this? And everybody's got a little bit of something different. Mm-hmm. So we're all still learning from each other. And I think it's nice that even though my attending's been doing this forever, she's like, oh, that is a good point, you know, and kind of just putting in everybody's different things. So as long as you get a good attending who's willing to teach you, the transition wasn't really difficult for me. It was a lot of learning, and it was a big learning curve, mostly for the well visits, but the sick visits, you're seeing a little bit of everything in the ER.
Thank you. Apologies for my dogs in the background in advance. Baha, I apologize if I did not say your name correctly. Baha wants to know, how did you choose pediatrics?
I always loved pediatrics. Ever since I was a little kid, if you asked me what I wanted to be, I said a pediatrician. The reason I picked my emergency medicine rotation was because it had a large pediatric population at that ER. I live in Philly. I applied for a job at Children's National in DC and got the job. And they really wanted me because they were really trying to build a research program at the time. So they're like, you have everything. Like, you have the PA background, you have the research, like you could really help us out. They were really trying to sell it. And we were talking a little bit about oversight before this as well. One of the reasons why I didn't take it is, one, my family and my support system was in Philly. I wasn't going to have anybody down there. And two, they have their main hospital where the PAs kind of run almost like the urgent care side of it. So ankles, lacerations, like you weren't seeing the traumas and stuff like that. At the main hospital, you were just running kind of that fast track part of the ER. But then they had a second hospital, which was in like a very underserved poor community, and there was no attending on site. So the PAs were like running the codes, running everything. And I'm a little bit too much of an emotional person that I did not feel comfortable leaving school and going right into this job where I could be running a code on a 3-year-old the next day. So that was one of the reasons. I forget what was the original. Sorry, I get distracted. What was my original question?
No worries. How did you choose pediatrics?
Oh, so I applied for Children's National, wanted pediatrics with that. In the city at the time, nursing unions were very prominent. So CHOP and St. Chris weren't even really hiring PAs. Like, you had to like know somebody to get a PA job. So the ER that I worked in was right outside the city in the suburbs. And they had much higher peds population because everybody wasn't going to the children's hospitals in the city. So that's why I chose it. I just always felt comfortable with kids. I feel like I'm able to have more empathy for kids, because even if the parents are a little crazy, they didn't ask for that. They didn't ask to have crazy parents. My kid probably has crazy parents too. She probably says the same thing about me. But you get like all mama bear, but I feel like you could take a step back because you're like, you know what? This kid's like an innocent party. We got to take good care of them.
Fair. Thank you. So we've got a couple of folks asking about Drexel. One's on a pre-PA track and asked if you have any advice specifically for the bridge program.
So we had a bunch of people in the bridge program. I wasn't too familiar with it. So my year, I guess there are like 3 or 4. I think there's a lot more in this bridge program now, where you kind of go into your undergraduate knowing that you want to be a PA and kind of go straight through the program. My only advice for that was, when it came time to get jobs, the people who took a break between undergrad and grad school had a lot more of that like real life experience. So I would try to do something in your undergrad years before you're doing clinicals and things like that. Do some of that stuff that people would do in between undergrad and graduate school. Get a job, scribing, do extra shadowing, just something to have more of that experience. Because I felt like a lot of people that did the bridge program, that was kind of their one downside. They were usually really highly intelligent. That's how they got into the bridge program to begin with. So it wasn't a great thing. But when you go to a job interview, they're looking at the full picture. So they want to know you have that customer service skill. So if you say, I'm really good, I have all hundreds on all my tests, and they're like, okay, so what are you doing in this patient interaction? You're like, I've only seen patients on clinicals, They're like, okay, well, we're looking for somebody with a little bit more experience. That would be my only thing, is try to get some more outside stuff, especially before your clinicals, to have that on your resume and be able to talk about it for the after part. I think academically it's perfect.
Awesome. So someone else, Valerie, is asking if there's anything for the Drexel application other than grades that she should be focusing on.
Focus on who you are. Like I said, this is an interview. It's like a relationship. They're going to love you or they're not going to love you. So there's nothing that you can say. There's no keywords that I'm like, say, go in. If you say these 3 keywords, you got it. That's what they're looking for. They're checking these boxes and making sure that you say all 3 of these things. It's not like that. They want to have a conversation with you. They want to get to know you. They want to get to know why you're doing this, and kind of what motivates you, what pushes you, and how you got here.
Awesome. Ethan, I love Ethan's question.
Uh-oh.
Ethan says, hello, I wanted to ask how whack the hours are for working in emergency.
So they're pretty whack. So it depends. When you first start, you're low man on the totem pole. So you're going to get all those shifts that nobody wants. You're going to be working New Year's Eve at midnight. You're going to be working Christmas morning. You're getting all of those shifts that nobody wants. The longer you're there, the more seniority you get, the better your shifts get. But our schedules were all over the place. Like, we wouldn't do like any back-to-back. So it's not like I would go in from I don't know, like I wouldn't do like a 5 to 2 shift and then go back for like 5P to 2A and then go back for 5A. Like they wouldn't do anything crazy like that. It would be like a gradual shift, but it wasn't like I had a 9 to 5. So I might be like 5 a.m. to 1 p.m. on Monday. And then I would be 10 a.m. to 4 p.m. on Tuesday. I would have off on Wednesday. Thursday, I'd go back for an overnight. So you would have your schedule ahead of time. You'd have your schedule a month ahead of time to kind of figure it out. But especially being low man on the totem pole, you kind of got what shifts were given to you.
That does sound kind of whack. Sandra wants to know what the most challenging thing you had to go through during school was.
That's a good question. That's a hard question. I don't know that I have like a specific situation. I quit PA school about 4 times. Dr. Patrick Goff was our director of the program when I was there. I at least went up to him 4 times crying. I'm like, I quit PA school. And he's like, you're going to be back tomorrow. You don't actually quit. I'm like, you would just get so overwhelmed. Like it would be that one thing. It would just be like that little needle that would just go on the top. Like, it would be something it would be like, I tripped walking across the street today. I can't do this anymore just because you have so much pressure. It'd be like the thing that you don't think that's going to take you off. But I don't think there was like one specific thing. It was really just the overwhelm. How I got through it, it was really that mind-body balance. Like I knew that I needed to do hot yoga. I needed to take that 45 minutes for myself at least every other day. If I didn't get my exercise in, we weren't going to the gym at lunch. I was going to go in mental overload. So kind of find what your release was. And like, that was my release. Like I just needed to do like some cardio exercise, get it out, breathe, do a little bit of meditation, and come back. But it's more the overwhelm in general than like one specific thing.
That's great advice for not just PA school, but life. Kevin would like to know your thoughts on residencies and fellowships after graduation.
So this was a little bit newer. So this was kind of just starting when I got out of PA school. So a couple people did like surgical residencies, or a couple people did emergency residencies. The program that the hospital that I went to didn't have an organized residency per se, but they'd been doing this for years. So they just had it set up that you kind of got like residence pay for the first year and you were an extra. So for the first few months you worked there, you weren't seeing your own patients, you were an extra, you were training. They knew you were right out of school. So it was like a much less pay. So it was kind of like a residency. I don't know what other people's experience are, but like when I was going job searching, nobody asked me like, oh, do you have these like residency certifications? What other certifications do you have? It seems like a lot of the SPs like don't really know too much about it. So maybe in some of the bigger hospitals, people are asking for that. But from my experience and looking, and again, this was all just starting. I feel like they were really getting popular like when I was finishing school. But I mean, I think it's great. The more training, the better. You're kind of getting thrown into it with a little bit of knowledge from everything. But I don't really know in the job world how it's holding up and what people are doing these days.
One thing I would just add, if it's okay, when I went into neurosurgery, I looked at doing one of the formal residency programs, but a friend in trauma introduced me to a guy, said he would train me. And so I went that route, and we agreed to kind of a lower salary for 2 years.
Yeah.
But I'll tell you this, for 2 years, I mean, I was glued to this guy. I was a shadow, anything he wanted done, any consult, any paper, everything. And the 2 years to the day I walked into his office and he just looked at me and laughed. He says, you know, I was expecting this, because he knew basically at that point, either now I can command a salary that I want, or he's going to do this all over again. Because now I have experience I could market elsewhere. So that might be a little advantage of not doing a residency. And I'm not saying don't do a residency, but you know, if you start off with somebody that will train you and you get along well, that person's going to keep you around.
Yep. I agree.
Good point. They do mention those residencies to us frequently, especially for emergency med, for what it's worth. Miranda would like to know, she says since COVID-19, she's been struggling to find PAs to shadow in person. She's done multiple internships, but if you have any tips or tricks in finding shadowing opportunities that you'd like to share.
So multiple ways. So I know that you have some shadowing opportunities available. I would say I've gotten a lot of people just reached out on LinkedIn. They're like, we see you're a PA, we're in Philadelphia, we're interested in pediatrics. Can we come shadow? And I feel like the more open they are, I've had some people that like send me back the schedule. They're like, what is your availability? I'm like, oh, I have these couple days available, like Monday's this, Tuesday's like, well, I'm available on the 15th of the month from 1 p.m. to 1:30 p.m. When you send back emails like that, I honestly, not that I don't care, but I'm not going to even respond because I have 800 things that I'm doing. I have like my kid running around. I'm driving to gymnastics. I'm getting calls from patients. I'm not going to go and sit there and be like, they could come for a half hour this day. So if you're pretty open to when you could shadow, then I feel like you could get more opportunities. But yeah, like just reach out and never underestimate, like always talk to people. I talk a lot. So this is why my background in engineering wasn't very helpful, because they wanted to put me in a little quiet room to do like neuroengineering. And they're like, don't talk or listen to music because you're going to mess the electrics up. I'm like, oh, I can't do this. But talk to people. Like you go to the diner, you go to the restaurant, talk to people. I can't tell you how many people like I've just talked to in random situations, like waiting in line at Disney World. And they're like, oh, I'm going to PA school. I was at gymnastics, and the gymnastics instructor's kid is in PA school. And she's like, oh, I overheard you're a PA. And then we got talking. She's like, can my daughter come shadow you? I'm like, yeah, sure. You know? So don't be afraid to talk to people. You just never know who or where is going to connect you with somebody. And just reach out. The worst they could say is no or not reply.
So true. Finley asks, can you specialize in pediatrics?
As in like a residency? I think there are residencies. Like I said, I'm not super familiar with that, but that's all I do is pediatrics. So.
Sandra wants to know how you overcame, I am guessing, the struggles of PA school. I think that was her original question.
Again, focusing on what my mental needs were, which was exercising, taking good care of my body and myself, and a good network of classmates. So pretty much everybody I know who went to PA school still has that close-knit network of friends that even if you talk once a year, it feels like you talked yesterday because you got so close. PA school for me wasn't very competitive, I want to say. It wasn't like, I don't know, in grade school, we were like, oh, who's getting 100? Who's getting a 99? Who's getting a 98? It was pretty much like we're all in this boat together and we're all kind of rowing along to keep the boat afloat. So everybody was kind of just helping everybody. I had some friends who were like, I am really good at this. Some friends were like, I'm horrible at this and I'm good at this. And just figuring out what everybody's little niche is and making sure your group has somebody in every category so you could work together and help each other. If it wasn't for friends, I don't think I would have got through.
School is definitely a team effort, and thank goodness for that. Okay, this is Sarah's got a little scenario here and then a question. She says, I work in dermatology as a medical assistant. Friday, a 6-year-old patient came in for warts. The dad stated he was not happy that the first and only treatment of cantharidin hadn't worked. I stated typically with a young age, the doctor will try the less invasive treatment, seeing that LN2 may be painful. After leaving the room, father came out and said he was very unhappy with me stating that the LN2 would be painful and I should never say anything in front of a 6-year-old. I'm guessing regarding the pain.
Yeah.
What is your advice in order to state it differently? Both a doctor and a PA stated they would have said it the same.
You're never going to make everybody happy. So that's been the hardest thing to learn in life. My attending told me, if you're making everybody happy, you're doing something wrong. I teach even the younger kids that are having problems at school, like the kid who I had with bullying. I said, other people's opinion of you is their opinion and you don't need to know it and you don't need to worry about it. People are unhappy for their own reasons. They just want somebody to take it out on. Did you say it wrong? Probably not. I try to, again, nicer being in the outpatient world, seeing these families a couple times. Sometimes I will pull a patient aside. Like if I know I have a very anxious kid and you say that they're getting a needle, I'll like put it on the computer and be like 3 shots and kind of turn the computer to show the parents. And then I'll be like, want to discuss, or do you want to talk about it later? Some kids need that prep at the beginning of the visit. I am going to get 3 vaccines. Some kids you cannot tell until right before you're going to give it to them. So it's nice knowing the family a little bit more, but everybody has a different personality. no matter what you do, you could do something for 100 people and 100 people think that that was the perfect way to do it. And that 101st person is going to think you're the worst person ever. So just trying to be as kind as possible. And it's a customer service industry, you know, just being very apologetic. The more apologetic you are, the easier things kind of roll off their shoulders. They really just, a lot of people just want empathy. Like they just want somebody to empathize with them. Like, my kid has had this is frustrating. They're ripping it off. They're scratching it. Now they have 20 more. We came in for this. They probably had a $300 copay for this treatment. And so you think you're doing something good by being like, I'm not going to cause burns on your kid that they're going to be in pain for the next few days. But then the parents seeing it as, I want a one and done. And sometimes I'll have that discussion with parents. Like, it'll be things I'm like, listen, I really wouldn't treat this right now. So I had a kid come in, it was a newborn, and they were there every day. The kid had a high bilirubin, and then the kid had something else. The kid was there every day for the first week of his life. And then he got a tear duct stenosis. So what do we do when the kid has a tear duct stenosis? We start with this little eye massage. If it doesn't get better in a few days with eye massage, we have them come back and do a swab and do like a chlamydia culture and send it for aerobic, just make sure there's nothing crazy growing. And make sure that nothing got into their eye, like coming out of the canal. And so usually we give them a few days. And I looked at this dad, and you could just see that this dad was so run down. And I was like, I'm going to give you an option. Here's what I would typically do. I would typically tell you, go home, do this. If it does, it's going to get better in a few days. If it doesn't come back, we're going to swab you. But you look pretty run down. Do you want me to just swab your kid today? It's not comfortable. It's not the greatest, but it's going to be over in a few seconds. And I want to do what you want, you know? And the dad's like, I don't want to have to come here another day. He's like, he's been crying the whole week anyway, like, just do it, you know? So kind of just, the more you do this, the more you'll get feels for the families and what they want and how to give them options, you know? Like, your way is not the only way of doing things. The more you include the family or the patient into your treatment plan, the better. Because that's, a lot of times that's what they want. They're not mad. They just want to be included. They don't want to be told this is the treatment. They feel like they don't have an option, and then it didn't work. So just kind of just including them more from the beginning, I guess. Sorry, that was a long-winded answer.
No, it was great. Kevin asks, this is a good question. I'm not sure if you might know this, but I've noticed several PA startup side businesses. Hi, James. Mentorships, Botox injections, etc. Do most PAs have a good amount of spare or leisure time to do that?
It depends on what your specialty is. It depends on what you're looking for. I had one friend who I worked in the ER with. She was working 2 ER jobs. She was like doing 1 ER job per diem and 1 ER job full time. And her goal was, I want to just pay my student loans down. I'm going to live with my parents. I'm going to get my loans paid off. And all I want to do for the next few years is work, 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 so that I don't have any student loan debt after this. And then I have some friends and myself who are like, I want to have a good balance. I don't know. I feel like eventually, I don't want to say you get bored with things, but you like pick up these little things that you're like, oh, this is going to be a good idea. Like when my kid was little, I was like, I'm going to sell Usborne books. And I sold books for 6 months. So I feel like people do like these little things on the side. You'll see a lot of these like mom to mom things. We were talking about, there's like a physician assistant mom group. So you'll see people like be like, oh, I can't talk about this on this group because we're not allowed to sell it, but I have this side business if you want to message me. I feel like people do it just to kind of keep things entertaining and different. It all depends on what your goal is, but you could make your career whatever you want it to be. You could be in the office 24 hours a day. You could be there part-time 3 days a week. It's kind of how you set it up for yourself.
All right. Finley followed up on her original question about whether you can specialize in pediatrics. And she says, like, an example, like a peds neuro or a peds endocrinology. So I'm guessing
absolutely.
Subspecialized. Kind of
absolutely. One of my friends right out of school went right to peds cardiology at St. Chris's in the city, and they started training her. And same thing with your situation. It wasn't a formal residency, but once they put all that training in, they're like, we don't want you to leave. And then she was able to, her husband got a job somewhere else. She was really able to market herself really well having this experience.
Kayla is asking whether an MCAT is required to apply to PA programs.
I don't know. You would probably know that better than me because I graduated a long time ago.
Yeah, I don't know of any that require the MCAT James might correct me there.
No, I think there's 6 that require the PA cap.
That's what I was going to say. There's like a new test.
Yeah, but it's probably not going to stick around. It was something developed that it just hasn't caught on like I think they thought it would. So the schools that do require it, I know of a couple that even they require it, but you just have to have it completed by the time you start school. Like you don't even have to have it to get an interview. Don't even have to get accepted. No.
Yeah, for what it's worth, I wish they didn't do the GRE.
Well, I only applied to schools that didn't require the GRE. Not my first shot, so
it's terrible. Hey, Kendall wants to know, what would you say were the benefits and the downsides of being in a large hospital trauma center versus being in a private practice setting?
I guess the benefits were you got to see a little bit of everything. One of the other benefits, since it was a large trauma center and you were that extra person, you got to shadow, you got to learn a lot. It was very hands-on, whereas maybe in like a smaller private practice, you're going to see a few things, but you're not going to see as much as you see in a large trauma center. And because they need more people, they were very willing to train and get you on board as quickly as possible, because the more hands, the better. There's always a shortage. I think it was really good training being at a big hospital. And I guess it was more, I don't want to say more formal. It's not like we had organized lectures and stuff, but they had done this so many times. Like the attendings there had been there so long. They had trained so many PAs in the past, whereas it was a little bit different in the outpatient world where my SP was like, I've never had a PA before. You tell me what you want me to do, you know? So that's kind of one of the downfall. It could be a good thing. And you get a lot of independence in a smaller practice. You have a lot more oversight. So again, it all depends what you're looking for.
Awesome. Sailor is asking what your days looked like in PA school. Did you have classes 8 to 5, Monday through Friday, or what was that schedule like?
It's probably a better question for you. Yeah, I feel like that was about right. I kind of block it.
Yeah, we try to. Well, yeah, we're in school about 8 a.m. to 5 p.m. every day. Sometimes we'll get out at 4. But yeah.
And then you go out with your friends, have a night out, travel a little bit.
Library.
Not the library, right? Go out to the library.
Charmaine wants to know how you studied in PA school.
I don't know if they still let you do this, but as long as we asked permission, we were allowed to record lectures. I was a very auditory learner. So if I heard something, like I would remember like where I was when I heard it. So that's always what I would do. I would always listen to my lectures and take notes in class. And then I would come home and I would re-listen to the lectures, especially on those years, like during that time when I was working, because I had a long commute. I would just put them on in the car, listen to the lectures there, and kind of have that extra time. I would go through all the material on my own, figure out what I didn't know, and then find people who knew that. And then in our study group, we would all bring our questions. We would all have done like kind of our independent re-listening, doing questions, going through all the practice, and then coming to me like, I don't understand this. And just having each other teach it. I feel like when your peers are teaching it to you, they're going to give it to you in 3 different ways. There's not just one way to learn things. So maybe the way that person 1 describes it is going to go straight over your head. But by the time you get to person 3, you're like, oh, that makes so much sense. So really listening to lectures, studying on my own, and then kind of crowdsourcing for the rest.
Yeah, great point. That came up with heart block today. I think I explained it to one person, and for whatever reason, one of those explanations stuck.
Yeah.
What are some of the best study tips you have?
Again, this is probably a you question. I'm getting a little bit nervous. I have like my PANRA to take. I'm very excited that I'm doing this new option that I only have 25 questions a quarter and I get to use up to date. I'm very excited for this.
That's what I did. I did that for my last one.
Was it good?
Yeah, I was, I guess, in the pilot program. So I would do it again in a heartbeat.
Yeah, I have not heard one bad thing about it. There are like all of those PA podcasts. So especially on clinical rotations, I would listen to podcasts for all of my commutes. Like I said, I'm a very auditory learner. Some people are good with reading. I'm like all over the place. So if I read something, I could read this same line 5 times and I have no idea what I just read. So just listening to those podcasts, listening to those lectures.
Mm-hmm.
I think, and for what it's worth, I know you mentioned you used to record lectures. I think with COVID, most of the programs just automatically record all of their lectures.
That's true.
Now,
yeah.
Which is awesome. I mean, it's one good thing that came out of COVID. So they just record all of ours and post them up to a site for us to review. Is your peds clinic Monday through Friday or 7 days a week? Haley would like to know.
Yeah, so our peds clinic is 6 days a week. Again, my boss is absolutely amazing and let me make my own schedule. So I made it around when my kid's in school. So I work 8 a.m. to 2 p.m. Mondays, Wednesday, Friday, so that I could drop her off at 7:15, pick her up at 2:45. Thursdays, I get out a little bit early. Thursdays, I get out at noon. So if I need to go food shopping, go to my doctor's appointments, I have a few hours to do that while she's still in school. And Tuesday nights, because patients love evening hours, so I do one late evening a week. So I have a babysitter one night a week. I go in at 10:30. I start my lactation group till 11:30, and then I work 11:30 to 7:30 seeing patients. That's obviously not a full schedule. So how do I make up for that? I work 2 Saturdays a month. My little one goes to her dad's house 2 weekends a month. It works out absolutely perfect for me because what else am I supposed to do on those weekends? So I go on 2 Saturdays a month and it worked out. It worked out for my attending. It worked out for me and I got the schedule I wanted. But no Sunday hours.
That's awesome. Natalie is asking how important you think hands-on clinical experience is prior to PA school. She wants to know if someone is at a large disadvantage if they take a non-traditional path or don't work in an explicit healthcare setting.
I don't think you're at a major disadvantage. I did clinical neuro research. So I did like NIH stroke scales and things like that. I had a lot of people who were EMTs who had so much more experience. And when it came to a lot of the clinical stuff, they were the people that I wanted to go to because they've seen this stuff, like they've seen it in action. So I don't want to say that you're at a disadvantage if you don't have it, but you're definitely more at an advantage. I feel like it's more people that don't have it than do, because a lot of people scribe and things like that. But the people who had that hands-on like EMT type stuff and worked in the ER as techs and saw this stuff hands-on, when it came to clinical stuff, there were definitely times that I was going to them and I'm like, I know you've seen this a bunch. Well, what do I do now? But they're going to prepare you regardless.
Haley would also like to know if your research background, how that benefited you, or how you feel that affected your application.
For the application, good. In my career, I don't know. Did it really affect what I'm doing? Probably not. I love it. I still love research. Eventually, I'd like to kind of add more research components on. I do feel like being a clinical research coordinator and having had people that I was training and kind of just all of what that encompassed and having all of that knowledge under me was really good. It was definitely a selling point when I went for my interviews. I don't think it needs to be research in particular. I think it could be anything, but it's more kind of, you have your leadership role, you know how to delegate, you know how to pick up what's needed, regardless of what field it's in.
Absolutely. Sandra says, thank you for answering our questions on the topic of shadowing. Can I just go to a hospital and ask them to meet the PA?
No, I would go to like the hospital is not going to get back to you. I would go to like LinkedIn or Facebook groups and find like PAs in particular. We'll even have people just, if you're interested in pediatrics, like we'll have people look up all the pediatric offices in like one area and just go on their websites and get the PA's email address and call the office and be like, hey, can I have their email address? Or if like it's not on the website, and reach out to them. The more one-on-one it is with the PA, the more willing I feel like we're going to be to help you out a little bit.
Yeah, actually randomly found someone wearing a PA shirt in the grocery store before.
Yeah.
And I was just like, hey, are you really a PA? I need to shadow. They let me do it.
Yeah.
So you'll never know. Just talk to people. Emily asks what specific type of engineering your background is in.
Biomedical engineering was my general, and then my concentration was neuroengineering.
Was it hard for you to get your prerequisites for PA school with that background as an engineer?
It was annoying, but not hard. So I felt like a good amount of people in biomedical engineering went to medical school. So they already had all of these things into our curriculum. Some of it was annoying. So since I did an engineering program and Drexel's a quarter system and not a semester system, even though I was going to Drexel's PA program, they still didn't understand for some reason the quarter program in undergrad, even though they do the same thing. So there were some courses that were like, oh, it's not really enough credits. So I had to like take an extra online course. Some of the schools required like you need like a speech course, which in engineering you don't talk to anybody. So like that was like something I had to go back. So it wasn't difficult. It was just more annoying than anything else because there's not really good loans for postbacks.
I bet. There is another question. I used to be an MA at a pediatric clinic, and sometimes parents would refuse to have their kids seen by a PA because they think they're not as qualified as an MD. How do you deal with this type of situation?
Well, when I first started as a PA, I took it very personally and was very upset by it. And now that I am more seasoned as a PA, I'm like, you know what? I probably don't want to be seeing that patient anyway. So I have a patient who's just going to argue with you because you're a PA. I'm like, that's fine. You can wait and see my attending. Like I'm at the point in my career where I'm like, I will take care of your sick kid, but if you want to wait, I'm not going to sit here and argue and try to sell myself to you when I could be taking care of another patient. So I feel like that's something that comes with time. And again, in the very beginning, like you would walk into a room, like whether it was ER or pediatrics, they'd be like, I don't want to see you. I only want to see a doctor. And I would take it so personal, like, oh, I'm a horrible person. They absolutely hate me. Like, what did I do? Like, you just walked in the room. It's just their personality. It was just what they grow up with. Some people, especially if like in the outpatient world, you could educate them, be like, I'll totally do it. But like just in the future, if you want to see me, like I could still prescribe. Some people think you can't give them medicine, that you're just going to do like a history and they're going to get pushed to the side. So kind of just explain, yeah, like I'll totally go get the attending for you, or we'll totally change the schedule. And the more accommodating you are, this is customer service. But in the future, like if your kid needs anything, I still do like history and physicals. And if I ever need anything and I don't feel confident, I'm going to go grab Dr. So-and-so anyway, and bring them in the room and just make sure they agree with my plan. A lot of times after that, like small explanation, like, oh, I do history and physicals and prescribe and refer. And if I don't feel comfortable, I'll grab somebody. They're like, oh, okay. They're a lot more willing to see you. But you have some people that are just like, I only want to see an MD. That's what I deserve. And I'm fine with that.
Thank you for that answer. Samantha would like to know if you studied the same way in undergrad as you did in PA school, or did you have to change your study habits?
Totally had to change it because in engineering, everything's math, individual. I had never studied in a group in undergrad. So that was a big change for me because it was just a different type of material that I was learning. So maybe for like some of my science labs and things like that, we did group work, but a lot of the engineering stuff was individual. So it was a big change.
Awesome. Baha would like to know if, and I am so sorry if I'm pronouncing that wrong, would like to know if you're interested in public health.
I'm interested in it, yes. I didn't specialize in it in particular. I know Drexel does have kind of like Masters in Public Health program that people would do in conjunction. A lot of people, not a lot of people, but I know some people who had dual degrees in like public health and physician assistant and are doing amazing things. It's just not my area in particular.
All right, this is our last question. Any
perfect timing
burnout advice, which is also perfect timing for where we're at in school.
Kind of like what I said before, taking care of yourself. There's only one of you. You're going to burn out. And just not taking everything so personally. You're not going to be perfect. Nobody's going to be perfect. You're going to get stuff wrong. In the beginning with patient encounters, because I still consider clinical as part of your schooling, but especially with patient encounters, I would go over everything I said in my head after a visit and be like, oh, I should have said it this way, or I should have said it this way. And like, would get so down on myself. And again, after doing this for a while, you're like, everybody messes up. Like you're just going to say stuff and it's just going to happen. And sometimes patients appreciate, depending on who the patient is, sometimes patients appreciate like you're a person too, you know, like I'll tell them like, I'm not perfect. Nobody's perfect. And they appreciate like you are actually a person. You're not just like this computer who's going to sit there and be like, you have symptoms A and B. Let's put it in the system and see what we get back. You have this. And a lot of times I talk through my process with patients now. And I'm like, here's like, if I'm like sitting back, I'm like, I don't want you to get nervous. Like, here's what I'm thinking. There's like 3 different ways to tackle this. Like, what's going to work for you? And I think that's kind of like a lot of my burnout in school and on clinicals was kind of just that getting down on myself type thing, being like, oh, I didn't do it perfectly. I should have said this, or I should have had this script. just trusting yourself. And the more self-care you do and the more confident you are in yourself, the less the burnout's going to be. Because, you know, stuff's going to happen. I'm doing the best I can. There's nothing else I could do. I can only do the best that I can.
Great. Well, again, I want to thank you, Kristen and Christina, for helping out tonight. And Kristen, thanks again. I mean,
not a problem.
I knew this would be a great session. You really bring a lot of great knowledge and answers to the questions. Really, I appreciate your time. Again, thank you for your time, Kristen and Christina. I appreciate everything you guys have done. It was a great time.
Thanks so much.
Thank you.
And then